Hello, this is the Unit 4, Module 12, Chapter 24B presentation. Herpes simplex viruses, HSV1 and HSV2, produce a variety of infections involving mucous membranes, the central nervous system, and on occasion, visceral organs. Herpes labialis is the most common manifestation of reactivation HSV1 infections. The lesions may involve the hard and soft palate, the gingiva, tongue, lip, and facial area. HSV1 or HSV2 infection of the pharynx usually results in lesions in the pharynx and the tonsils. Lesions of the tongue, the buccal mucosa, or the gingiva may occur later in the course. The fever lasts for between 2 and 7 days. Exposure to herpes simplex virus at mucosal surfaces or abraded skin sites permits entry of the virus into cells, and virus replication begins almost immediately. The genome of herpes simplex viruses is linear, double-stranded DNA that encodes about 84 different proteins. During the initial phase of infection, virus replication occurs in ganglia and nearby neural tissue. The virus then spreads to other mucosa through migration of the virus via the peripheral sensory nerves. Latent infection persists in ganglionic cells in the general region of the initial infection. The mechanism of reactivation of herpes simplex virus is unknown. HSV infections occur worldwide, and infection with HSV1 is acquired more frequently and earlier in life than with HSV2. By the time they are 50 years old, more than 90% of adults have antibodies to HSV1. Cold sores are most commonly seen among children and young adults. Again, the transmission can result from contact with people who have active ulcerative lesions or persons who have no clinical presentation of infection but who are shedding HSV from their mucocutaneous surfaces. HSV reactivation on genital skin and mucosal surfaces is very common. Herpes simplex virus infections are treatable with antiviral chemotherapy. For mucocutaneous infections, acyclovir and penciclovir have been mainstays of therapy. For HSV encephalitis and neonatal herpes, IV acyclovir is the treatment of choice. Mumps is an acute systemic viral infection classically associated with the swelling of one or more of the parotid glands. The prodrome of mumps consists of low-grade fever, myalgia, headache, and anorexia. Mumps parotitis, which is the swelling of the parotid or other salivary glands, lasts more than 2 days and develops in about 70 to 90% of symptomatic infections of mumps. Mumps is caused by a paramyxovirus with a negative strand, non-segmented RNA genome that encodes about 9 different proteins. The viral hemagglutinin neuraminidase and the fusion proteins are responsible for cell binding and entry of the virus into cells. The incubation period for mumps is about 19 days, and the virus is transmitted by the respiratory route via droplets, saliva, and fomites. Mumps virus is typically shed from 1 week before to 1 week after the onset of symptoms. Persons are most contagious 1 to 2 days before the onset of their clinical symptoms. The primary replication of the virus occurs in nasal mucosa or upper respiratory tract mucosal epithelium. Humans are the only natural hosts for mumps virus infection. Mumps is generally benign, and the therapy for the swelling of the salivary glands is symptom-based and supportive. Analgesics and the application of warm or cold compresses to the parotid area may be effective. The mumps vaccine contains live attenuated virus. Acute infections of the GI tract are among the most common of all illnesses. The most prominent features of GI infections are fever, vomiting, abdominal pain, and diarrhea. Their presence differs with different diseases and different stages of infection, but the occurrence of diarrhea is a central feature. And diarrhea is the basis for the classification of GI infections into three major syndromes: those that cause watery diarrhea, those that cause dysentery, and those that cause enteric fever. The most common form of GI infection is watery diarrhea. Dysentery begins with the rapid onset of frequent stools, but they are smaller in volume and contain blood and pus. And enteric fever is a systemic infection where the origin and focus are in the GI tract. The pathogens of lower digestive infections that are bacterial include the Enterobacteriaceae, Shigella, Salmonella, E. coli, and Vibrio cholerae, Campylobacter jejuni, and Clostridium difficile. Watery diarrhea is produced by enterotoxin-secreting bacteria, such as Vibrio cholerae and enterotoxigenic E. coli, which is abbreviated ETEC. Both of these cause fluid loss without cellular injury. Organisms that cause dysentery can produce inflammatory and/or destructive changes in the colonic mucosa, either by directly invading or by the production of cytotoxins. This damage is what produces the pus and blood that are seen in dysentery. Enteric fever is more complex than that of watery diarrhea or dysentery. Enteric fever generally involves penetration by the organism of the cells of the small bowel and their subsequent spread outside the bowel to the gallbladder, the liver, the mesentery, or blood and lymph systems and organs. Bacteremia is common with enteric fever, occasionally causing metastatic infection in a variety of other organs in the body. The transmission modes for these diseases are usually endemic infection, which has a high incidence in children related to the fecal-oral transplant and their lack of immunity. Another transmission mode is through epidemic infection, where hygiene is poor or after major disasters, for example, typhoid fever, cholera, or shigellosis. Another transmission mode for these diseases is traveler's diarrhea, which people contract from eating fresh fruits and vegetables and other uncooked foods that have not been properly sanitized or washed. The fourth transmission mode is through food poisoning. The infections herein are associated with improper cooking or storage of foods. Finally, the transmission mode of hospital-associated diarrhea with Clostridium difficile and rotaviruses, for example, that cause outbreaks in hospitals. In most GI infections, the primary goal of treatment is to reduce the symptoms and maintain fluid and electrolyte balance. In general, common antidiarrheal medications will work, and antimicrobial agents are usually not indicated for self-limited watery diarrhea, but antibiotics can be required if the infection is more severe and is dysenteric. Some enteric infections, such as typhoid fever, are always treated with antibiotics. Prophylactic regimens can be available for traveler's diarrhea, but they're not very effective because they can't cover all the possible causes of traveler's diarrhea. Cholera is an acute diarrheal disease that can, in a matter of hours, result in profound, rapidly progressive dehydration and death. Infected individuals with cholera may be asymptomatic or with only mild diarrhea. Others will present with the sudden onset of explosive and life-threatening diarrhea. After a 24 to 48-hour incubation period, cholera characteristically begins with the sudden onset of painless, watery diarrhea that very quickly becomes enormous in volume. Again, if fluids and electrolytes are not replaced, this hypovolemic shock and death may ensue. There's usually no fever associated with cholera. The cholera stools have a characteristic appearance. They're gray, slightly cloudy, with flecks of mucus, and there is no blood. The odor is somewhat fishy, and these are referred to as the classic rice water stools because of their resemblance to the water in which rice has been washed. The complications of cholera derive exclusively from the effects of the water loss and electrolyte depletion. Cholera is a toxin-mediated disease. The watery diarrhea is caused by a potent protein enterotoxin that's released by cholera vibrio in the small intestine. Once established, the organism produces cholera toxin, which is a classic A-B toxin. The B part binds to a glycolipid on the surface of epithelial cells, and it delivers the A subunit into the cytosol. The A subunit causes accumulation of high levels of cyclic AMP. High cyclic AMP activates the chloride transport system in the epithelial cells, and it leads to an accumulation of sodium chloride outside of the cells in the intestinal lumen. Water moves passively out of the cells, and the fluid accumulates in the lumen. When the volume of that fluid exceeds the capacity of the gut to reabsorb it, you get watery diarrhea. Unless the wasted fluid and electrolytes are replaced, shock will follow. The natural habitat of Vibrio cholerae is coastal saltwater and estuaries. Humans actually become infected accidentally, and they are vehicles for the spread of cholera. Ingestion of water by human feces is the most common means of acquisition of Vibrio cholerae. The consumption of contaminated food also contributes to the spread. There is no known animal reservoir for Vibrio cholerae. Again, death from cholera is due to hypovolemic shock. So the treatment of individuals with cholera first and foremost requires replacement therapy, oral rehydration, and the level of dehydration will depend on the patient's age and weight. So the volume should be rapidly restored, and adequate hydration has to be maintained to replace the outgoing fluids. Shigella is a non-spore-forming gram-negative bacterium that, unlike E. coli, is non-motile and does not produce gas from sugars. Several Shigella species cause disease. The Shigella pathogenesis is due to bacteria invading intestinal epithelial cells by inducing them to take up the bacterium after the initial crossing of the epithelial barrier through M cells. The organisms also induce apoptosis of resident intestinal macrophages. Once inside the cytoplasm of intestinal epithelial cells, Shigella triggers the cytoskeletal rearrangements inside of those cells necessary to direct its own uptake. The Shigella-containing vacuole in the cell now is then quickly lysed, and it releases bacteria into the cytoplasm of the cells. Intracellular Shigella next use cytoskeletal components inside that cell to propel themselves into neighboring cells. This series of events permits bacterial cell-to-cell spread. Shiga toxin, produced by Shigella dysenteriae type 1, increases the disease severity. The toxin causes general inhibition of cell protein synthesis. The Shiga toxins that gain entree into the circulatory system eventually bind to target cells in the kidney, and they may result in hemolytic uremic syndrome. Current public health recommendations in the U.S. require that every Shigella case be treated with antibiotics. Hand washing after defecation or handling of children's feces while changing diapers and before handling of food is recommended. Stool decontamination of equipment and hands is useful in limiting the spread of infection during Shigella outbreaks in a hospital setting. There's no vaccine available for Shigella. E. coli is the most common cause of urinary tract infections and gram-negative rod sepsis. It's one of the two most important causes of neonatal meningitis, and it's the agent most frequently associated with traveler's diarrhea that causes watery diarrhea. Some strains of E. coli are enterohemorrhagic and cause bloody diarrhea. The reservoir of E. coli includes both human beings and animals. The source of E. coli that causes urinary tract infections, for example, is the patient's own colonic flora that colonizes their own urogenital area. The source of E. coli that causes neonatal meningitis is in the mother's birth canal. This infection is acquired during the baby's birth. In contrast, the E. coli that causes traveler's diarrhea is acquired by ingestion of food or water that are contaminated with human feces. The epidemiology is complex for E. coli infections, and it's different for the various E. coli strains. What's important from this slide is that you note which E. coli infections produce toxins. The mainstay of treatment for all diarrheal syndromes is the replacement of water and electrolytes. The use of prophylactic antibiotics to prevent diarrhea in travelers should generally be discouraged, especially in light of high rates of antimicrobial resistance. The treatment of the different types of E. coli infections depends on the site of the disease and the resistance pattern of the specific E. coli isolate. There's no specific prevention for E. coli infections, but general measures can be taken to prevent certain infections. For example, the incidence of urinary tract infections can be lowered by the judicious use and prompt withdrawal of catheters, and in recurrent UTI infections by prolonged prophylaxis with urinary antiseptic. Traveler's diarrhea can sometimes be prevented by the prophylactic use of Pepto-Bismol. Ingestion of uncooked foods and unpurified water should be avoided when traveling in certain areas.